Okay, start.
Hi guys, today's topic, I have selected some short topics on discussion on orthopedics. We will start. Okay. First is regarding the blood supply. We will discuss three things. One is blood supply of the femoral head and talus, and another thing is scaphoid. They are asking because of the significance of avascular necrosis, so that we will discuss the anatomy, blood supply part. So this is the proximal femur with head. You will see it is from one source is from the obturator artery. The branch is called artery of ligamentum teres. You can see you will have the ligamentum teres here. You will have the branch which is called artery of ligamentum teres, that is from the obturator artery. So another thing is you will have common iliac, from where you will see external and internal iliac. From external iliac you will have femoral artery. Femoral will again divide into superficial and deep femoral artery. Wherever you will see the word profunda means deep. So deep femoral artery is known as profunda femoris artery. From the profunda femoris artery, you will have two branches. One is median circumflex artery, another one is lateral circumflex artery. So lateral circumflex artery is over the anterior aspect. Medial circumflex artery is over the posterior aspect. Here the most important blood supply is medial femoral circumflex artery. From medial femoral circumflex artery, these two, lateral and medial, will form extracapsular anastomosis, ring anastomosis. From here, from this ring, you will have ascending cervical vessels. That too, lateral ascending cervical group of vessels is the important branch to the head. That is known as subsynovial retinacular branch. Okay, you will see here. So this is the deep femoral artery or profunda femoris. Medial circumflex is going posterior. Lateral circumflex is coming over the anterior aspect. These are all the ascending cervical vessels. Okay, this is regarding the artery of ligamentum teres. So these are all the three areas of blood supply. What is the importance? Okay, in case of Perthes, up to 4 years, you will have epiphyseal and metaphyseal vessels. From 4 to 8 years, you will have only epiphyseal vessels. There won't be no metaphyseal vessels because there is a facial growth plate, it won't cross. So that it is most common in that age group. Up to the 14 years, you will establish another artery of ligamentum teres. After adolescent age or after adolescent, you will have all three arteries: artery of ligamentum teres, metaphyseal and epiphyseal vessels. So in case of white people as Scandinavians, you will see that there is a delay in development of the ligamentum teres. So that's why Perthes is most common in white than black. This is the importance of blood supply of femoral head. So going to the talar blood supply. So here you will have three sources. One is from anterior tibial artery, another one is from posterior tibial artery, another one is from peroneal artery. You can see here, one is from anterior side, one is from posterior aspect, another one is from lateral aspect. Okay, you will have tarsal sinus over the lateral aspect. Tarsal canal is situated on the medial aspect. Okay, so anterior tibial artery will give a branch dorsalis pedis. Okay, this is regarding dorsalis pedis. Then posterior tibial artery will give to tarsal canal. Lateral peroneal artery or perforating branches, it will give to tarsal sinus. These are the simple thing you can remember. This is a good diagram I have taken from my internet. Three blood supply. One is from anterior tibial artery. It will give a branch to your dorsalis pedis. Lateral side, you will have perforating peroneal artery. It will travel to and supply tarsal sinus artery. From posterior tibial, you will have tarsal canal artery. This is regarding the blood supply of talus. Why it is important? Because neck fractures are more prone for avian. In talus, you will have classification, Hawkins classification. You will see type 1, the risk of avian is 0 to 25, then up to 50. In type 2, Type 3, you will have 75% risk. Type 4, which is described by Canal and Kelly, there will be 100% risk for AVM. We all know that what is Hawkins sign? It is a sclerosis, which is indicating the regeneration of the blood vessels. Okay, Hawkins sign is a good sign to see in talus fractures. So we all know that type 1 is undisplaced, type 2 is displaced with subtalar joint association. Then type 3 is with subtalar and ankle joint. Type 4 is with subtalar ankle and talonavicular joint. Okay, this is regarding the talus. Here you need to know that only three things: anterior tibial artery, one branch; posterior tibial artery, one branch, that is to the tarsal canal, and it has a deltoid artery. Third thing is lateral side, you will have peroneal artery. Tarsal sinus is situated laterally. It will give to tarsal sinus artery. Okay, this is regarding the blood supply of talus. The importance is type 4 will have worse prognosis. Going to the scaphoid blood supply, here important thing is you will have AVN and non-union of scaphoid. The thing is, here the blood supply is from radial artery. So radial artery. This radial artery will have two things. One is from palmar branch, another one is from dorsal branch. So 80% of blood supply is from dorsal branch. 20% is from palmar branch. Okay. Palmar side we will call as volar tuberosity vessels. Okay. Volar tuberosity vessel. Dorsal side you will have dorsal ridge. So 80% of blood supply is from dorsal branch. 20% of blood supply is from palmar branch. This is regarding the blood supply. It has a retrograde blood supply. We all know that. Here you can see this is going towards the retrograde side, proximal pole. Any damage at the most common site of fracture is waist fracture. So we all know there is a rule known as 70% rule. 70% of carpal bone fractures are scaphoid fractures. 70% blood supply is towards the dorsal branch, and 70% risk is towards the proximal pole, non-union or AVN. Okay, this is regarding the retrograde blood supply of the scaphoid. So we have seen femoral head blood supply and its importance. We have seen talus and its importance. We have seen scaphoid and its importance. Going to the Trendlenberg gate, just an addition. We all know that Trendlenberg sign, normally this is regarding the integrity of the abductor mechanism. You will see that if the person is going to stand on the normal leg, this is a normal patient, one side leg, opposite side pelvis will go up. This shows the integrity of the standing leg, that is opposite side integrity of the abductor mechanism is good. This is regarding the normal side. For example, this patient is having the defect over this limb. Okay, so once if he is going to stand on the affected limb, opposite side pelvis will droops down. This will show what it will show. It will show the integrity of the abductor mechanism is lost in the opposite limb. Okay, so which limb he is weight bearing, that side he will having the pathology. Okay, so here the lurch is towards the same side to compensate the center of gravity and to clear the foot from the ground for walking. We all know that lurch is towards the same side, drooping of pelvis is towards the opposite side. This is regarding the Trendlenberg. What are the components? They will ask what are the components of Trendlenberg? Yes, power, fulcrum, lever arm. Okay, power. In power, you will have muscle. Muscle, you will have two things. One is, yes, gluteus medius is supplied by, yes, superior gluteal nerve. Okay, it is regarding any injection palsy or damage to the superior gluteal nerve. One is gluteal muscle paralysis, that is gluteus medius paralysis. Second one is any muscular dystrophies. This is regarding the muscular causes. And another thing is polio. These are all the muscular causes. That is power causes. Then going to the lever arm, that is neck of femur fracture. Any discontinuity in the lever arm or greater trochanter area, you will have lever arm defect. Fulcrum is hip joint. posterior dislocation. You need to divide into painful and painless. Acute, actually painless is most common, because once painless patients start walking, it will be seen in a post-traumatic cause like posterior dislocation of hip joint, neglected posterior dislocation of hip joint, and developmental dysplasia of hip. These are the two areas where you will see fulcrum defect. Muscular cause, lever arm cause, fulcrum defect. In lever arm, you will have coxa vara also. It may be a congenital or acquired coxa vara. In Perthes, there are two things you can get. One is regarding the coxa vara, you will get trendlenberg gait. And another thing is here, the neck development is, neck and head development is up to 12 to 14 years. The same age, greater trochanter grow up to 14 to 17 years. In Perthes, you will see there is a defective formation of the head and neck region. But the thing was, greater trochanter will grow upwards. You will see the impingement of the greater trochanter. This will lead to even abductor weakness. So you can get trendlenberg gait because of power defect also in Perthes. So that when doing surgery, we will do varus derotation osteotomy plus trochanteric epiphysiodesis. This is the reason we are doing both surgeries combined. Okay, this is regarding trendlenberg's gait. Thank you guys. These are all the things today we have discussed regarding short topics.
Hello everyone, this is Dr. Sheenam Bansal. So today we will do the distal humerus fractures and shaft humerus fractures. So firstly, I will start the distal humerus fractures. In the distal humerus fractures, you need to learn about the firstly classification, and then mainly there is treatment. In any fracture, the two things are very important for the examinations. First is classification, the other is treatment. Firstly, what in the classification we have AO classification, and in the AO we know for the humerus it is 1 and for the distal it is 3. So firstly 1 3 A1 2 3, then B1 B2 B3, then C1 C2 and C3. In the A1 there is avulsion fractures, then there is simple fractures, then there is wedge fractures. You can also remember it in the order of alphabetical order: avulsion, simple and wedge. And in the B1, B is the partial articular, this is the totally fully intra-articular, and this is the extra-articular. So B1 is the lateral sagittal, then medial sagittal, then in the frontal plane, that is in the coronal plane. Then we have the complete articular. Complete articular in this, like we have this, there is simple articular and simple metaphyseal, that is T-shaped. But in the C2 type, there is simple articular, but there is multifragmentary or wedge shape. So this is Y shaped. Okay. Then C3. C3 is, this is intra-articular comminuted and this is also comminuted. Means multifragmentary articular and multifragmentary metaphyseal. This is fully comminuted, that is C3. So in the treatment part, firstly in the classification, we have done the classification. Then we will do the X-rays, radiographic features. You will get the AP X-ray done, lateral X-ray done, fraction views done for planning. You will also need to get done the CT. Okay, then we have in the treatment. In the treatment approach, we have many approaches. Firstly, you need to know about the main approaches. Firstly, there is tricep splitting approach, then tricep sparing approach. Then there is also tricep reflecting approach. Then reflecting, there is R. So it is also called Bryan-Murray approach. You can see there is also many R's. Okay. Then you have fourth is the olecranon osteotomy. Olecranon osteotomy is also called the Chaveron osteotomy. Okay, then you also have the trap approach, that is also called O'Driscoll approach. Okay, so there are many approaches. Now, the olecranon osteotomy, mostly olecranon osteotomy is done, that is Chaveron osteotomy is done. The main disadvantage with this approach is that you need to do the other fixation for the olecranon fractures. You need to do the TBW or K-wire fixation, and you may damage the anterior interosseous nerve, and then you can use the 90-90 configuration plates or parallel plates. Okay, you can use the 90-90 or parallel plates configuration. Now, what is the AO principle? What is the O'Driscoll? That is new principle. This is 90-90 plates. One plate is on the medial side and one plate is on the dorsolateral. One is on the dorsolateral and one is on the medial. And here in the O'Driscoll, we have parallel plates. And screws in the AO plates, in the AO type fixation, screws are not passed from the plates. Intercondylar screws are not passed from the plate, but in the O'Driscoll, screws are passed from the plate, and screws are used of the bigger size, so they can engage the opposite side also. Okay, so these screws are bigger so that they can engage the opposite side also. So this is the AO method and this is the O'Driscoll method. Now, second is the humeral shaft fractures. In the humeral shaft fractures, firstly, you know there may be damage of the radial nerve, and if fracture is spiral, distal third, then it is called Holstein-Lewis fracture. Firstly, we will do the classification, that is AO classification, then we will do the treatment. In the classification AO, you know 1, 2, A1, A2, A3, B1, B2, B3, C1, C2, C3. These have been eliminated. Now A1, SOT, spiral, oblique and transverse. B2 is simple wedge fracture. This is comminuted wedge. This is simple segmental. This is comminuted segmental. Okay. Now you will get done the AP view, lateral view, etc. Now in the treatment, you have three options. Either you can do the splintage and after that Sarmiento bracing, and either you can do the intramedullary nail, either you can do the ORIF plating. Now, what is the indications of Sarmiento bracing? You can do it if fracture is falling in the, if fracture is fulfilling the criteria of acceptability. What is the full criteria of acceptability? If there is anterior angulation of less than 20 degree and less than 30 degree varus and less than 3 centimeters short. Okay. In the polytrauma, even if even fracture is fulfilling this criteria, but if we have patient of polytrauma, then we will not apply splint, then we have to do the fixation. Okay. In the intramedullary nail, you can either do the antegrade nailing or retrograde nail. Intramedullary nail, so anterior to posterior screw can damage musculocutaneous nerve, and lateral to medial screw can damage the radial nerve. Okay. Intramedullary nail indications are, what are the indications of intramedullary nail? If you have the segmental fractures, if I have pathological fractures, and these are relative indications. If patient is of polytrauma, and plating. In the plating, you can, for ORIF, you have the indications of वही same polytrauma. If you have patient of polytrauma, you have floating elbow, bilateral humerus fractures. If you have open injury, if you have brachial plexus injury also, these all are indications of this. Then ORIF can be done by two approaches, anterolateral approach and posterior approach. In the proximal and middle, you can use the anterolateral. In the distal, you can use a posterior approach. Now, in the anterolateral approach, this is the extension of the deltopectoral approach. And posterior approach, you can use in the distal fractures. So complications, you know, infection, malunion, non-union, nerve injuries, etc. Radial nerve injury is not a indication for ORIS. Okay, because it may recover after the 3 months if it is neuropexia. So if it is not recovery, if radial nerve is not recovery even after 3 months, then get done the EMG. If in the EMG you are seeing the fasciculations or you can see the fibrillation. If you are seeing fasciculation, then congratulations, this is a positive sign of recovery. If you are seeing the fibrillations, it means you need to take the next step because your nerve is not going to be recovered. Okay, then take action. Then with this, we have completed distal humerus and shaft humerus. Thank you so much.